Hi, my name is Dr. Harry Witchel, and this is Lipids and Atherogenesis. It's part 2 of a 3-part series. And this is the summary of topics you're going to need for the examination. So, what do you need to know for examination purposes? This is a list that was provided in the class. The first thing is you need to know the relationship between lipids and lipoproteins and atherosclerosis. You need to know the cellular events in atherogenesis. You need to know the lipid oxidation and response to injury hypotheses of atherogenesis and their interrelationship. You need to know about high-density lipoprotein is and its role in reverse cholesterol transport. And you need to have an understanding of the multifactorial factors involved in atherogenesis, including the classical and newly emerging risk factors. These are what were presented in class, and we'll go through these one at a time for the next 10 minutes. So, the relationship between lipids, lipoproteins, and atherosclerosis. In a nutshell, cholesterol is abundant in fatty streaks, and fatty streaks are thought of as the precursors of atherosclerotic lesions. Now, the lipid hypothesis states that high blood lipid levels probably contribute to the risk of atherosclerosis. This hypothesis was proposed in the 1850s, and it was still debated as late as the 1970s, but it's now accepted, although the mechanism is not fully elucidated. We know that high total cholesterol levels are not directly correlated with coronary heart disease. That's because HDL, high-density lipoprotein, contains, quote, good cholesterol. So some of the total cholesterol levels are not necessarily in the process of causing vascular damage. Also, another reason why high total cholesterol levels are not directly correlated with coronary heart disease is that there are other coronary heart disease causes, such as smoking and high blood pressure. So you can have a person with perfectly low total cholesterol levels, but because they have these other risk factors, such as smoking or high blood pressure, they will have coronary heart disease. So HDL shows that high total cholesterol levels are not sufficient for coronary heart disease. Because there are other causes of coronary heart disease, that means that it's not necessary to have high lipid levels. So these interfere with the statistical association by having randomly distributed cholesterol levels. Nevertheless, we do know that cholesterol levels do contribute in a quite causal way to coronary artery disease. Here's an example from Cote et al. From the Journal of American Medical Association, in which they looked at the presence of conventional risk factors in over 87,000 patients with cardiovascular disease. And what they found is that the vast majority of patients who had cardiovascular disease had at least one risk factor. Almost 80% of them had one risk factor. Now, the conventional risk factors are hypercholesterolemia, hypertension, diabetes mellitus, and smoking. So this suggests that from a public health perspective, that you want to treat your patients who have any of the 4 basic risk factors, because if you get rid of all 4 basic risk factors, they will have a greatly reduced risk, because the vast majority of patients do seem to have one risk factor or more. Another way of looking at this from a research perspective is that if you believe having multiple risk factors should be the cause of cardiovascular disease, then what we see here is that over 64% of the patients have either 0 risk factors or 1 risk factor. That suggests either one risk factor is very powerful, surprisingly powerful, or that maybe there are some unknown risk factors which lead to the ultimate development of cardiovascular disease. So there are 2 different ways of thinking about this. One is from a research perspective, and the other is from a public health perspective. Next, you have to have an understanding of the multifactorial factors involved in atherogenesis, including the classical and newly emerging risk factors. So we've just described the 4 classical risk factors, which is hypertension, diabetes mellitus, smoking, and hypercholesterolemia. It's fairly apparent, and it's easy to understand, that risk factors are multiplicative. A patient with 2 or more risk factors has a much higher risk than a patient with 0 risk factors, or even a patient with only 1 risk factor. Nevertheless, we know that 85% of cardiovascular diseases have 1 or more of the classical risk factors. So from a public health perspective, this says focus on those 4. However, 15% of cardiovascular diseases have no classical risk factors. From a research perspective, that means that the classical risk factors are not the whole story. We need to understand newly emerging risk factors, which either form the basis of cardiovascular disease for those patients, the 15% of patients who have no risk factors, or that these unknown or newly emerging risk factors contribute dramatically and make one risk factor much more dangerous. Now we know that 45% of cardiovascular disease cases have only one risk factor. The question from a research perspective, is only one traditional risk factor enough to cause cardiovascular disease? Maybe everyone is being affected by these newly emerging risk factors. So what are the newly emerging risk factors? Well, you've been taught about modifiable risk factors such as high LDL cholesterol, high triglycerides, high HDL cholesterol, etc. But several that are worth thinking about include socioeconomic status. Now, these people often do have a poor diet, but there's something else going on that would lead to socioeconomic status being associated with cardiovascular disease. Also stress, that mental stress. What is it about mental stress that causes people to have risk of cardiovascular disease? Likewise, gender is associated with a risk of cardiovascular disease, particularly male gender. Also menopausal status. So women under menopausal age seem to be protected in some way, whereas men are not. So this suggests that there's probably something to do with estrogen, which may be a possible improvement for patients sometime in the future. Oh, there are also emerging coronary risk factors. Some of these are possibly modifiable, such as vascular dysfunction, oxidative stress and inflammation. There's also adipose tissue-related factors, such as insulin resistance and abdominal obesity. But there are also other unmodifiable factors which are not fully understood, such as maternal or fetal malnutrition. So that all of this suggests that the mechanism between some risk factors and cardiovascular disease is not fully understood. These represent opportunities for future drug development. Now, what are the cellular events in atherogenesis that you need to know for the exam? Well, unspecified damage occurs to subendothelial layer of a blood vessel. It might be oxidative damage. It might be some form of lipid accumulation. But this damage is very important in leading to monocytes migrating to the damage. These monocytes, once they're inside the blood vessel and face to face with the damage, will become macrophages, and these will phagocytize the lipid. Now, some of this lipid is going to be oxidized. It's going to be taken up but not necessarily eliminated by the macrophages. The macrophages, while there, will release cytokines, which will lead to greater inflammation. The macrophages will also release myeloperoxidase, which will lead to peroxide production, such as hydrogen peroxide, which will lead to yet more oxidized lipids. And these macrophages will become foam cells. These are all crucial events that you must understand in order to understand atherogenesis. The next thing from the list that you need to know about is the lipid oxidation in response to injury hypothesis of atherogenesis and the relationship between the two. You know that LDL enters the subendothelial space. LDL is retained in the vessel wall. LDL is oxidized, and this oxidized LDL is probably the injury in the response to injury hypothesis. This oxidized LDL is taken up by macrophages, which triggers the macrophages to release cytokines. This contributes to the chemoattracting monocytes and inflammation, and this ultimately causes the foam cells to lyse, increasing inflammation and thus leading to yet more injury. So here what you see is that this requirement, the lipid oxidation in response to injury hypothesis, what you need to know about this is almost the same thing as what you need to know about the cellular events that we talked about in the previous slide. They're all one and the same idea. The next thing you need to know about is HDL, high-density lipoprotein, and its role in reverse cholesterol transport. How HDL can take free cholesterol out of the periphery. It can even remove it from macrophages in lesions, all of which requires the ABC1 transporter protein. The HDL appears in two stages. HDL can be seen in the blood in a nascent form and in a mature form, nascent being the immature form. To get to the mature form, free cholesterol has to become cholesterol esters, and that happens via the enzyme LCAT. Now, mature HDL can also send the cholesterol esters to be either taken up in the liver, which is atheroprotective, or it can end up in VLDL via the enzyme CETP, or chylomicrons can also take it up in that way.